Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 14, Dr. Rick Davis gave us a fantastic lecture on lateral curl tensioning for the ultra-wide tip.
I appreciate all your attention, and I think Cameron's going to throw a few questions if there's time. If not, we'll bid you adieu.
Wow, Rick, you know what the worst thing is about these webinars is you can't hear like 500 surgeons around the world applauding your talk.
Oh, well,
yeah, thank you.
I'm just happy they enjoyed it.
Oh man, but to have an hour and 15 minutes of really delving into a subject is great, eh? So
it's a subject that's hard to present in 10 minutes, and that's what I'm usually given at national meetings, unless I get to do a keynote address. And this was the keynote to end all keynotes. So I'm grateful to you for giving me the time to express the whole concept, and not only, just usually I get snippets and then people are all confused, but we were able to take it from A to B today, which I was thankful for.
That's awesome. Do you want to stop sharing your screen, and then I'm going to start going through some of the questions. They're just pouring in from all over the place here. So I'm going to kick off with one of the first questions, quite an interesting question through the YouTube channel. He wants, Irving wants to know, how do you avoid asymmetry in the columella with a lateral to lateral septal extension graft?
Good question, Irving. You can use septal extension grafts in one of two ways, end to end or side to side. If the septum is in the perfect sagittal midline, it's best to use end to end, unless you're trying a very aggressive projection and counter rotation. It may not be strong enough. Side to side is stronger, but it has an inherent asymmetry. If there's a pre-existing asymmetry, say the septum is slightly off to the left, then put your graft on the right and overlap it, and it will compensate. If there's no asymmetry, if it's a really wide nose, it probably won't show up very easily. But if it's a skinny nose, try to do it side to side and maybe use splinting grafts or extended spreader grafts to stabilize it if it's not stable on its own. When you're making a nose smaller, it's usually stable. When you're trying to elongate it or project it, then you're fighting the skin envelope. And unless the skin is very elastic, it's tough. I see Dean sitting there. Hey, Dean. So it depends on the nose, and there's a lot of factors to consider as to how you place it and how you secure it.
I'm going to combine a couple of questions. There are a few questions about the sutures that you use. Maybe some comments on your sutures that you use in different areas of the nose.
I use permanent sutures almost never. The one exception is when I'm trying to anchor a graft to the anterior nasal spine through a drill hole. I will sometimes use Prolene or nylon, just because that is so critical to the rest of the nose, and they sometimes break loose when you use polydioxanone or PDS. Polydioxanone 4.0 is good for really stiff cartilage, but it makes bulky knots, and I prefer 5.0 if the cartilage is soft enough that I can mold it. One of our previous speakers said they always use 6.0, and I think that's just too insecure. There's a controversy over whether you use an atraumatic needle or a reverse cutting needle. I've always used a reverse cutting needle. I've always preferred that. I think it penetrates the cartilage more readily, and I've never had a problem with that needle. There are other exceptions to those sutures, but usually when I'm trying to reconstitute the nasal framework, I'm using polydioxanone or PDS, either 4.0 or 5.0, depending on how stiff the cartilage is and how critical that component is. The more critical, the more secure the fixation.
Thank you. Bernardo wants to know, what software do you use for pre-op simulation?
I use a very old software that's called United Imaging. It's market-wise United Imaging. United Imaging kind of went by the by. It's recently been purchased and is being reincarnated. It's not so much the software, it's what you do with it. There's scores of much cheaper and very capable morphing softwares available now. A lot of them are coming out of Europe. I don't use 3-dimensional. I like the 2, but I don't have a problem with people using 3-dimensional. It would be it would be more important to have just something that you're comfortable with, that you learn how to morph quickly, than any particular brand. But I do use the United Imaging.
Okay. It's 2 questions coming in from Dr. Wittold. He'd like to say, so he says, why don't you perform lateral crural release and transposition, ? Especially when you have tension when suturing the lateral crural to the septal extension graft. And don't you worsen the cephalic malposition and lateral crural resting angle with spanning sutures?
There's a couple of questions there. With Dean sitting before me, I'll say the reason I don't use transposition very much is because I'm not Dean Toriumi, and that is a very nuanced and finesse procedure, number one. Number two, it's always intimidated me a little bit to completely release the lateral crus from its blood supply, both superficially and deep. Having said that, there are numerous advantages to it, and if you put your lateral crural strut graft more toward the caudal margin of the transposed crus, it's not interfering with the internal valve, and I think it does a good job of both form and function. I guess we're all creatures of habit, and I've been doing this tensioning stuff since day one, and I'm just comfortable with it. So, I suppose I could take time and learn to do it, but I'm just happy with what I got. What was the other question? I've forgotten.
I'm gonna carry on to one that's popping up from 2 different people so far. Richard and Siren both want to know, what about an overprojected nose? How different is your technique there?
Well, that requires a mega tongue and groove setback, sometimes having to amputate the foot plates or the foot pods off the medial crus to enable you to slide that medial crural column down the caudal septum, sometimes pushing it back, setting it back, but dropping it down so that you're over deprojecting the nose at your starting point. And then when you have an ultra wide tip that is then under projected because you compensated with the tongue and groove setback, you can use the lateral crural steel to reproject it and use the septal extension graft to control the amount of rotation. So I showed a couple cases where I did that and was able to keep the lateral crural cartilage arch intact and not divided at any point, unless you count clipping off the medial crural foot pods as a division. That is also useful because a lot of profile deformities have problems with the nasal base. If you look at the patients with tension noses and caudal excess of their septum, you're only doing part of the rhinoplasty if you neglect that. And this fixes the profile of the base, and at the same time makes your ability to narrow an ultra wide tip even more potent. So there's dual advantages. You get a profile enhancement and you get a frontal view enhancement. You maintain the continuity of the lower lateral cartilage arch. It's more work, but in a large percentage of noses, if you don't do it, you're kind of neglecting the full operation.
Okay, there's 2 questions here about the articulated rim grafts. It reminds me of last year, and I was chatting to you about how difficult one of the sutures were, and you said to me, Sana, you're using your left hand. Anyway, they want to know is where exactly you pocket the graft, and then what percentage of your cases do you actually use articulated rim grafts on?
Okay, I can answer the last one pretty easily. Whenever I have cartilage, I pretty much use an articulated alar rim graft. They're very forgiving, and if sewn in symmetrically and secured properly, they will stabilize the alar margin. Maybe you don't need it, but I sleep better at night knowing that there is a direct structural buttress to the alar margin that will hold it in place, especially since I do so many revision cases where the margins are coming to me retracted to begin with. The pocket will be lateral to the marginal incision where the graft protrudes out beyond the lateral crus. Exactly where you want to put it depends on how you're trying to shape the alar margin. If you're just putting it to maintain its current configuration, in other words, you're not trying to bring the nostril margin down or push it up, you just put it right where it's resting. I tend to sew the grafts at 90-degree angles to sagittal, so that they're like, you know, bird's wings sticking out perpendicular to the long axis of the nose. And then I make my pocket right over top of it beyond the marginal incision. But if I have a revision case where there's been an alar retraction, I will sometimes either not put that in any pocket, just put it, push the alar soft tissues down and slide it into the dissection I've already done in the area of the sesamoid cartilages to drop that whole alar complex a little bit. Sometimes I'll even angle them down a little bit away laterally so that they push it even further. And, you know, these aren't usually revision cases. These retractions aren't always symmetric. So one you might pocket and one you may not. You're trying to individualize. And, you know, the pocket, I have learned, should be very superficial. I try to make the pocket as close to the outer surface of the skin as possible, because it looks better. The reason I like these grafts is because they create a surface topography that's a natural thing. And if you put them underneath the lateral crus, you negate that benefit. So I try to get them under the skin, very superficial. I've also found that if you put them deep under the superficial skin, on the outer skin, that you'll see them bulging into the nasal vestibule internally, and it's unsightly. So you'll hide them better, conceal them better, and get a better cosmetic benefit if you put them near the superficial aspect of the outer skin. Your pocket should be almost poking through the skin.
Exactly. I think that kind of ties into the question Ahmed has. I think his question is, are there indications for using the articulated alar rim graft and alar rim grafts at the same time? And I think maybe he's not quite understanding that.
Well, I use floating grafts sometimes. Those are the traditional ones. That's basically when I'm not worried at all about retraction, but I'm a little more concerned about a little bit of pinching because the turning point is medialized. But either one or the other. I don't use both at the same time. You might put a composite graft above it and still use a rim graft, but it's either going to be a articulated or a floating, or neither. But I would say that in this day and age, I don't leave them without rim support very often. That's pretty unusual.
Okay, old Rui has an interesting question, and maybe with Dean on as well, it's going to be even more interesting. He wants to know, do you ever find it necessary to reposition caudally the lateral crura in case of cephalic malposition?
To reposition caudally the lateral crural in cases of cephalic malposition. Well, cephalic malposition is an interesting phenomenon. If you look at the corpus of the crus. In many of these noses, the corpus has a bulge along its medial aspect. So visually, it looks like the crural axis is shifted medially. But in reality, the caudal margin of the crus may be in the proper place. It's just the volume of the corpus is all skewed medially. That's number one. So those could be managed by tensioning. Number two, when you have caudal excess, your septum grows too long, your maxilla grows too long away from your forehead, and it's pushing your columella further and further away from your nostrils. That's changing the orientation of that crus. And so when you push it back up, it changes that angle. As your columella moves, I mean, you just take your own nose and pull your columella down, you'll see that it looks like you're creating malposition. You are. But when you do these tongue and groove and setbacks, which I do a lot, you're taking that angle that's very, non-orthotopic, and you're creating an orthotopic simply by moving it up. So there's, Dean very effectively moves the lateral aspect of the crus downward, but you can move the medial aspect of the crus upward and achieve the same thing.
Oh, sure. Rick, I'm gonna have to bring this little one into land now. We've been at it for
we're costing the University of California a whole bunch of tuition money right at this point.
There are so many questions still coming, and there's a lot of hands up, etc. Remember, please, if you want your CME credits, fill the form in. It's gone out on the chat, and also the the evaluation. Next week, we're into our end now. Hey guys, we've come around that corner, the 200 meters. We can start seeing the home straight. We've got 4 more lectures to go.
Clubhouse turn is in front of us.
We've got Peter Polhazy and Jeff Marcus next week, and then it's our last week. And so before we finish now, so this is my final question for you. If you had to say, what are your 3 most important things about rhinoplasty to the people around the world who are watching you, what would those tips be?
First of all, be your own worst critic. Look at your results as objective as you possibly can. It's hard not to be emotional sometimes and to give yourself the benefit of the doubt, but try to analyze what you've done, both what you've done right, but probably more importantly, what you've done wrong. That requires long-term follow-up, and it's hard to get people in this day and age to come see you for any length of time, unless, of course, they have a little problem, this little thing, and then they kind of never want to stop seeing you. But try to get good follow-up. Pick your battles wisely. If you're a young surgeon, choose battles that you're likely to win, and save those really difficult noses for when your skill set is more mature. You don't want to do overreach early in your career. The old saying, one happy patient might get you 1 referral, but 1 unhappy patient might cost you 20 referrals. And on this day and age of the internet, 1 mistake gets scattered, or 1, might not even be a mistake, just an unfortunate outcome gets spread to the planet. So you can ill afford to have screw up. So be conservative and, ask for help, ask for consultations, reach out to colleagues and get other opinions. That's one thing about these forums that are so wonderful, is that I see all the time, here is a case I'm about to do. What should I do here? That's the beauty of all this, is we're helping to educate one another, and a rising tide lifts all boats. So we're all getting better at this. We're all thinking more about it. We're all listening to other ideas. That's a wonderful thing.
Yeah.
So again, hats off to you, Cam, for making us all brainiacs here.
Yeah, man, it's amazing to have you guys coming on and watching. It's really incredible, eh? Rick, so honestly, from our side, thank you very, very much. Our wish for you guys is that you'd start operating soon again. Really, I hope your practice takes off better than it's ever been once everything's locked.
Your lips to God's ears, Cam. Thank you all for being here. I see lots of friends and colleagues that I haven't seen in a while. So I wish you all well, stay safe, and carry on, battle on, gang.
Cool, man. Thank you very much, everybody. Good
All
night.
right. So long, guys and gals.
All right.